Good morning, everybody. Good afternoon. This activity by the ICUDDR joins us together from all over the world, and we are proud to present this panel. This panel largely represents what is happening in this context of the pandemic in the continent and how universities have tried to adapt. So thank you to the first panel, development of remote tools, skills assessment strategies, training and supervision in the field of addictions and mental health. The Faculty of Psychology of the National Autonomous University of Mexico will be in charge of the panel. The university is known by its acronym, the UNAM. I'd like to greet the presenters and the speakers for this panel. Dr. Violeta Felix Romero, Minister Sandra Ferrer Reyes, Minister Alejandra Lopez Montoya, and Dr. Sylvia Morales. They're all great friends and collaborators of the OAE, the Inter-American Commission for Fighting Drug Dependency. I'm the chief of the Drug Demand Reduction Unit. So the Faculty of Psychology of the UNAM will be presenting this panel in their work with mental health and addiction, not just in the context of the pandemic, but also to showcase the work that they've been doing for a long time. First of all, I'll give the floor to Dr. Felix Romero, who has a graduate degree in behavioral sciences by the UNAM University. She also coordinates the specialization program in psychology at the UNAM University, and her main research line is evaluating implementations in addictions. She's a professor at the UNAM as well, and she's also in charge of supervising the training of undergraduate and graduate students. Dr. Violeta Felix, you have the floor. Thank you, Jimena, for the presentation. Good morning, everybody. Everybody tuning in today. For us, it's a real honor to share with you the work that we've been doing, and of course, highlighting the adaptations and the efforts that we've been doing and moving our activities to the online environment. So what we're going to be doing today is talk about the strategies for assessing professional skills in addiction and mental health that we've been developing.
Entonces voy a iniciar cuando hablamos de
So I'll get started. When we talk about evidence-based practice, we're talking about all of these activities from basic research in laboratories, from controlled research, until application in natural environments. When we say that we are doing evidence-based practice, evidence-based intervention, we mean those interventions that are based on basic conductual principles and research, and as health professionals, this allows us to implement interventions that have evidence of efficacy and effectiveness. Within these activities, we will center today on the implementation and adoption of these evidence-based strategies. When healthcare professionals put in practice this technology, these evidence-based interventions, we make a lot of decisions that allow us to adapt and adopt these procedures and use them in our natural scenarios. And it is also important to assess skills for the implementation. And this is also why it's also important to have direct observation of what healthcare professionals are doing and what treatment providers are doing in the
ejemplos de lo que hemos
scenarios.
estado
So we
desarrollando en
will be
materia de
showing some
evaluación de
examples
competencias
of
y que
what
hemos
we've been
estado además
developing in
aprovechando
competence
la
or skill
tecnología para,
assessment.
pues para
And we've been leveraging
mejorarlos,
the
para tener un
technology
mayor alcance,
to
para
improve
utilizar
them,
otro
to
tipo de
have
herramientas que
more
nos han
reach,
permitido
to
obtener
use other
datos
kinds of
muy, muy
tools that have
valiosos, que
allowed
son
us
algunas
to
de las
get
cosas que
very
les
valuable
queremos
data.
compartir el
And
día
these are
de
some
hoy.
of the things that we
Entonces,
would like
les
to
vamos
share
a
with you
presentar
today.
algunos ejemplos
So,
de
we will
estas
present some
estrategias de evaluación
examples
de
of
competencias que van
these
desde la evaluación de
skill assessment
conocimientos, que es una
strategies
evaluación que
from
se hace
knowledge assessment,
generalmente en todos los esfuerzos de
which
capacitación,
is
en todas las
done
actividades de formación de
usually in
recursos
all
humanos
training
y que es, digamos,
efforts, in
la
all human
evaluación
resource training
por default que hacemos
activities.
en
And this is
todas
the default
las estrategias de
assessment
formación y de
that we do
capacitación,
in all of the
pero que
strategies
cuando
for
nos vamos
training.
más allá de la
And
capacitación, cuando nos
when we
preguntamos
go
qué pasa
beyond
después de la
training
capacitación y
and
cómo los
ask ourselves,
profesionales de
what
la salud
happens
están
after training?
utilizando
How
estos
can
conocimientos y no
healthcare
solamente
professionals
conocimientos, sino
use
habilidades,
this knowledge, not just knowledge, but
aptitudes,
also
competencias
skills
en general en
and
su práctica diaria,
attitudes,
pues nos vemos en
competencies
la
in
necesidad
general?
de
How
plantear
are they
otro
using
tipo de
them in their
estrategias de
daily
evaluación,
practice?
como
Then
son las
we need
situaciones
to
simuladas
have
estandarizadas, que
other
ya les
assessment
platicaré en un
strategies like
momentito,
standardized
los casos
simulated
programados y la
situations, which I'll
evaluación
get into
conductual
later,
también de esta
program
implementación en
cases,
casos
and
reales.
behavioral
Entonces, vamos a
assessment
iniciar
in real
con la
cases.
evaluación de
So let's get
conocimientos.
started
Ustedes
with
saben que la
knowledge
evaluación de
assessment.
conocimientos pues es una evaluación que
You
se
know that
ha
knowledge
utilizado
assessment
tradicionalmente en el ámbito
has
de
been used
capacitación, de
traditionally
entrenamiento, de formación de recursos humanos.
in
Sin embargo, la
training of
tecnología
human
nos ha
resources.
permitido precisamente plantear
However,
estrategias de
technology has
evaluación
allowed
que se
us
han ido
to
adaptando a
have
los
assessment
contenidos, que se han ido
strategies that
adaptando
have
también a las
adapted to the
necesidades de la población
contents,
que está siendo
to the needs
capacitada o
of the
entrenada en estas
population that is being
intervenciones basadas
trained
en evidencia, como
in
es el caso
these
del
evidence
currículum
based
universal de
interventions.
tratamiento, que es una estrategia que
This is
hemos
a universal
montado
treatment
aprovechando también el
curriculum.
uso de la
This is a
tecnología ya
strategy that
desde
we
la
put
pandemia, pero
together
que en
also
función de
using
la pandemia nos
technology.
ha
We started
permitido
before
también
the pandemic,
tener un
actually, but
mayor
because of the
alcance
pandemic,
y que
we've been able to
pues en
have
una
greater
plataforma
reach with
móvil
it.
están
And
distribuidos los contenidos y están
in this
distribuidos
in a
ejercicios o
platform, we distribute
actividades de
the content
aprendizaje
and we
que le
distribute
permiten al
learning
participante
exercises
adquirir
and activities
conocimientos,
that
pero también
allow the
habilidades y
participants to
aptitudes con
acquire
respecto a
knowledge,
las
but
intervenciones
also
breves para consumo de
skills and
sustancias.
aptitudes
Y en este
about
caso, la
brief
evaluación de
interventions in
conocimientos pues
substance
la hemos hecho
consumption.
a través de
In this
preguntas de
case,
opción
knowledge
múltiple, de
assessment
falso y
has
verdadero,
been
pero
done
la
through
tecnología nos ha
multiple
permitido
option questions,
justamente
multiple choice
hacer algunas
questions, true
adaptaciones
or
que
false
implican la
questions. But
presentación
because of the
aleatoria de las
interventions, we'd be able to
preguntas,
adapt it,
de un banco de
for example, to
reactivos,
present the
elegir
questions in a random
aleatoriamente
order,
ciertas preguntas y entonces
choosing
validar los
questions
conocimientos
from
que
a
van
bank of
adquiriendo los
questions
participantes a lo largo de
randomly, and
este
then we can validate
entrenamiento vía remota. Y
participants'
por
knowledge
ponerles algún
throughout this
ejemplo de
remote
lo
training.
que hemos
And just
alcanzado
as
con esta
name an
evaluación de
example of
conocimientos,
what
pues es
we've
lo
achieved
que se
with this knowledge
esperaría en los
assessment,
entrenamientos y en las
well, this is
capacitaciones,
what
un
we would
incremento de
expect
los
in
conocimientos a partir de cursar este
an
tipo
increase in
de
knowledge
actividades, y lo que les presentamos
after
pues
going through
son
these
ejemplos
activities.
de
So
algunos de nuestros participantes
these
que
are
han
some
alcanzado un
examples
incremento
from
en sus
some of our
conocimientos
participants that have reached an increase,
estadísticamente significativo
a
en
statistically
comparación con
significant
el
increase in their
promedio de
knowledge
conocimientos que tenían al inicio de la
compared to
capacitación,
the knowledge
participantes
average that they had
acreditados que han
before the
cursado todas
training
las
or at the start of
actividades,
the
todos los
training.
módulos, pero también participantes que aunque no
Some
terminan
participants
todas
have
esas
gone through all the
actividades,
modules, all
también
the
logran un
activities, they've
incremento
been accredited,
significativo
but
de sus
also participants
conocimientos,
that don't finish
también
all
lo
the
logran
activities
por
have
perfil
significant
profesional.
increase
No
in their
hemos tenido la
knowledge.
oportunidad de trabajar
Also
con
by
personal de psicología,
professional
medicina,
profile.
trabajo social,
We haven't
enfermería,
we've
psiquiatría,
we've worked
y en
with
todos
people
los
from
casos se
psychology,
observa un
medicine,
efecto
social
del
work,
entrenamiento
nursing,
en un incremento
psychiatry,
de
and
los
in all
conocimientos
cases
haciendo uso de
we can
estas
perceive
herramientas
an increased
tecnológicas.
knowledge
Este
by
es un
using these
ejemplo de cómo
technological
se han
tools.
evaluado, se han
This is an
iniciado
example
estas
of
evaluaciones de competencias en el
how
nivel de
these
conocimiento. Sin
skill
embargo,
assessments have been
sabemos que
developed
los
in the level of
conocimientos no
knowledge.
son suficientes
But we
para
know that
validar la
knowledge
formación de los
is not
recursos
enough
humanos, y entonces
to
hemos ido más
validate
allá
human
en
resource
las
training.
estrategias de
So
evaluación,
we've gone
generando
beyond
estrategias que
that
nos permitan
in our
precisamente evaluar
evaluation
no solamente
strategies by
conocimientos, sino
generating strategies that
habilidades
allow
y
us to
actitudes
assess
y
not
en
just
general
knowledge,
competencias que
but
los
also
profesionales
skills and
ponen en
aptitudes
práctica
and
en
competencies in
su vida
general that
diaria profesional,
professionals
¿no?
have to
Entonces,
put
un
in
ejemplo de
practice in
estas
their daily
estrategias de
professional
evaluación son las
lives.
situaciones
An
simuladas.
example
Las situaciones
are
simuladas
simulated
son una
situations.
estrategia que nos ha
These are a strategy that has allowed us to assess skills in a standard way by assessing these simulations, it has a standardized script. So a situation is presented, pretending to be somebody needing care, and they present a series of stimuli and information to the participant. And then the participant is required to respond as they would normally do in professional care based on their knowledge and their training. It's very important to note that these situations are based on real clinical cases, typical cases. This allows us to generate an implementation sample for what healthcare professionals do in a reliable, standardized way. This way, every participant has the opportunity to behaviorally present their skills. And of course, they also get feedback on the different aspects of their execution. This way, we've been able to assess skills in a training about addictions. This is an example. It's not just a precocious assessment. It happens at 4 semesters and 4 times of evaluation or assessment, and the stimuli are presented through the simulation, and we can assess the effect of the training during the different times of assessment. These are the examples of 4 different therapists doing functional analysis, and what we can observe here is their progress in acquiring skills based on their training in the different assessments, based on a simulation. And as you can see, in most cases, there is a tendency to increase the acquisition of these skills and competencies. It's not just knowledge, rather, we are directly observing through video and audio recordings what is going on with the implementation. Another strategy that we've been working with, thanks to the technology, are the program cases or branching scenario. This strategy is the possibility of observing somebody's decision when faced with certain stimuli or situations. So we use technology to show the participant a video about a user who's being cared for. There's a series of stimuli, and the participant has options to choose from in each of the skills. And each decision takes them to a different branch, a different scenario. That's why the term is branching scenario. And then we can identify the professional's decision making and the path that they are taking in these program cases. We found very interesting things. These are preliminary data. At every moment of decision, these are the questions of each scenario. Substance consumption on the left, depression on the right. Blue bars are pre, red bars are post, and this is how professionals make decisions. For substance consumption, our participants have a lot of skills from the start that do increase, and they're rather stable. When we talk about the depression case, our participants are not as used to working with other healthcare problems, mental health problems. So we are focusing our efforts on tackling mental health comprehensively. And here we can observe how the increase is larger based on program cases in terms of decision making. And thanks to technology, we also have the chance of observing what happens in real situations through videos given prior consent by the participants and the patients. And what we can see here through this surveillance strategy of real cases are very specific things like behaviors and procedures that are effective for participants when they treat a case. This is an example of a case with dyads of healthcare professionals and substance users, and we identified the level of implementation for each of the procedures. And through a regression analysis, we determined which procedures are related to or predict regression in patients. And we can establish alternative behavior goals, consumption goals, and we can plan the intervention. And all these things predict success. And we couldn't have identified this any other way than directly observing the skills of the professionals and what happens in those scenarios. So to conclude, these strategies have led us to think about a lot of things. First of all, there is a need to have the political and institutional will so that this kind of skill assessment, this kind of research can be part of the daily activities, institutions, and healthcare professionals. These shouldn't be seen as separate. Within the daily practice of professionals, it is possible to generate evidence of what is working for them when they're treating patients. Of course, the use of technology as a valuable mechanism for evaluation and surveillance, which is necessary under these conditions that we are currently in. And this has implications for the ethical management of information. And this is important to consider in research and also in our professional practice. And this is the end of this section. Thank you so much. And I'm sure that my colleagues will complete these strategies. Thank you. Thank you, Dr. Violeta Felix, for your presentation. Now, I leave you with Minister Sandra Ferrer Reyes, Master of Addiction Psychology by the National Autonomous University of Mexico. She is a counselor of the Action Program to overcome the mental health breach, and she also supervises those graduate students. So, Minister Ferrer, you have the floor.
Muchas gracias. Bueno, justo lo que yo les voy a presentar también continúa
Thank you so much.
continuación a lo que ya presentó la doctora Violeta. Y yo les voy a
So this will
sobre
build
lo que
on
hemos
what
estado
Dr. Violeta
trabajando
presented.
desde previo a la
I'll be
pandemia,
talking about what
el
we've been working
entrenamiento
for
profesionales
since
de
before
la
the pandemic
salud
in terms
en el
of
ámbito justo de
training
salud mental
healthcare
y adicción.
professionals in addiction and mental
Entonces,
health.
bueno, previo a la pandemia, pues la capacitación se
So
realizaba
prior to the
forma
pandemic,
presencial, pero justo como ya lo han
training would
venido
happen in
comentando,
person.
durante la pandemia
But as
hemos
we've
tenido
seen,
que adaptarnos y
throughout the
utilizar la
pandemic,
tecnología para
we've
continuar
had
con
to
el
adapt
entrenamiento
and
de los
we've had to use
profesionales de la
technology
salud.
to be able to
Entonces,
continue
la
training healthcare
estrategia que hemos
professionals.
seguido para capacitar
So the
en salud
strategy that
mental y
we
adicciones
followed
es de forma
to
general
train
el
in mental
esquema que les
health and
presento a
addictions
continuación.
is in
Entonces,
general
la capacitación
the
va
chart that you
dirigida
can
a
see here.
profesionales de la
The
salud
training is
en un
aimed
primer
at
nivel de
healthcare
atención, es decir, que no
professionals
están
in the
especializados como
first
tal en
level of
salud
care.
mental.
That
Entonces,
is,
la
they are
capacitación va
not
dirigida
specialized in mental
a
health.
poder
So
brindarles las
the training is
competencias
aimed
fundamentales
at
para brindar
providing them
atención en
with
salud
the
mental.
fundamental
Entonces, la
skills to
estrategia que
provide
seguimos se basa en
mental
el programa
health
de
care.
acción para superar las brechas en
Our
salud
strategy is
mental del
based on the
ICUDDR.
action
Entonces,
program to
básicamente en lo
overcome
que consiste es un
the mental
curso
health
a
gaps,
distancia, ¿no?
MH gap.
Que consta de 4
It's
semanas, aproximadamente se
a
cursan
course
2
that lasts for 4
módulos y medio
weeks,
por semana. Y además de este curso
2.5
a distancia
modules per
para
week.
capacitar
It's
o entrenar
online.
a los profesionales de
And
la
on
salud,
top of this course to
también
train healthcare
utilizamos la
professionals,
plataforma Zoom para
we
brindar
also
sesiones
use the Zoom
asincrónicas que tienen la
platform to
finalidad de
provide
fortalecer
asynchronous
todas
sessions
las competencias
with
brindadas a
the
través del
aim
curso a
of
distancia
strengthening all
y
of the
también de
skills
resolver
provided
dudas que
through
pudieran
the
surgir durante esta
long distance learning course. And
capacitación
we
o
also
entrenamiento.
answer any questions that might
Entonces,
come up during the
ya
training.
una vez que termina el curso, pues aquellos
So once the
acreditas
course
reciben una
finishes,
constancia y
the people
además
who finish it, they get
de
a certification.
tomar este curso
And
a distancia que brinda
besides
a los
taking this
profesionales de diversas
long
competencias,
distance
también
course
evaluamos las
about
competencias que
different
pueden
skills,
tener estos
we also
profesionales de la salud,
assess
no
the
solamente para
skills that
implementar
these
esta
healthcare
estrategia
professionals
de
might
MH
have.
Gap, sino también
Not just for
evaluamos las
implementing
habilidades
the
que
MH
tienen
Gap strategy,
para
but we also
capacitarse, ¿no?
assess their
Entonces, no solamente
skills to train. So during this training, we don't just train promoters or professionals that can implement MHCAP in their own clinical practice, but we also want to train professionals so that they can be facilitators and trainers. In other words, so that they can replicate the training in their institutions. So the idea is for these promoters or healthcare professionals to be able to replicate this training in healthcare centers or institutions. And so far, during the pandemic, we have trained 4,084 healthcare professionals through this distance learning modality. In general, this is the content of the training. It has a prior assessment of knowledge and also an assessment through program cases like Doctora Violeta showcased. Once they go through this evaluation, then they can start going through each of the modules that make up the course, a total of 9 modules, which is similar to the content of the MHCAP. And each of these modules specializes mental health disorder. After this, there's a final assessment. It includes knowledge assessment and also program cases. And as I said, aside from the course providing the skills to implement MHCAP, we also want to train trainers, facilitators. So we have also started assessing the skills of healthcare professionals to train through direct observation. So in general, these are the data, the characteristics of the participants or healthcare professionals that had taken this course. As we can see, most of these 4,084 participants are psychologists, followed by medicine, then social work, nursing, and we have also trained professionals in other areas, chemists, engineers, specialists in pedagogy. They've also taken the course, and most of them are also, and the average age is over 35 years of age for all sessions. Here in general, I also present the results about the course. In terms of knowledge, there's an increase of knowledge after the course, and 3.8 average to an 8.0 average after the course. We can also see the grades that they've gotten in each of the modules. There's a bigger average on the first module that has to do with essential or fundamental practices to provide healthcare, followed by depression. That is where participants get the highest scores. And earlier, I also mentioned how besides providing training and for healthcare professionals in the skills to implement MHCAP, we have also incorporated assessing skills to train, to provide this training to others. And these are the results we've had so far with the participants.
Evaluación de competencias de capacitación. Entonces, para evaluar estas competencias de capacitación,
to assess these training skills, we use this list, and the idea is to use direct observation to identify which skills these professionals have, the potential facilitators. These checklist skills are essential for training, from planning and logistics to communication skills. So to do this evaluation, with prior consent from the professionals, we requested a video where they model how they provide the training by choosing a specific topic, whether it's depression or any other of the modules from the MHCAP. And through this observation, we were able to observe what their skills were. So far, only 19 professionals have participated. Most of them are women from different states in the country. These are some of the results that we identified. As I said, through this checklist, we can observe what the skills are that they had to provide a training. Before they provide it, so logistical skills like selecting the tool in case it's a distance training, what is the most functional tool depending on the participants. If the training is provided through dyads by somebody in specializing in social work, psychology, or psychiatry, and also the selection of the modules to provide it based on the specific characteristics of the participants. And some skills that are fundamental in the training, from presenting the facilitators to the material has to be standardized. Also, if they have the skills according to the topic that is being addressed or the disorder that is being addressed, whether they fulfill the objectives of the training, and of course the skills for after the training. So we can observe that the competencies from before almost all healthcare professionals have them. Now, for the skills that are used during the training, well, a lot of them are provided in most cases, but some are not present or are not present as frequently, such as carrying out activities that are in accordance with the number of participants to start the presentation or the training. And at the end of the training, we observe that few professionals use additional methods that can help the training be more effective. Here, I also show the basic skills or behaviors that facilitators need to exhibit when they are doing this training. We see that most of them have expertise on the topic. They also have expertise on the tool. They don't issue value judgments. They modulate their tone of voice. They can use a camera. They turn it on. But there are other skills that are not present, and they are also essential when providing a training. So, such as conductual trials to practice a skill and providing feedback about these activities. So this activity is not present, rather the skill, and therefore it needs to be reinforced in the trainings or in the assessment of the training skills. This ability has proven to be effective for the training to be effective in healthcare professionals. Some others are also pressed, we can't see a lot of them, like feedback about participation for the trainees. So these preliminary results let us to identify the skills that are present the most often in the healthcare professionals who will be replicating the training and which are not present, and therefore they need to be reinforced after this training. And some final thoughts. It's important to acquire not just knowledge during the training process, like Dr. Violeta said, but also the necessary attitudes and skills that can allow to increase the effectiveness of interventions. So, based on this, we can identify that it's important to incorporate into this distance training other tools that, besides knowledge, will allow us to identify and assess the abilities of healthcare professionals. In the case for skill assessments for assessing the training skills, Well, direct observation lets us to observe these skills and assess them to identify what the most appropriate or adequate procedures are for strengthening the training. Another thing that we've identified throughout this whole healthcare professional training activity is that even though training is really important for training healthcare professionals in assessment, follow-up, procedures in mental health disorders, the training is not enough. Surveillance and monitoring strategies are also important, and Alejandra will talk about this. This surveillance will be essential to monitor and identify that all of these procedures and skills that are learned through the training are actually being used in the MHCAP strategy.
Y bueno, por mi parte sería todo. Muchas gracias.
And
Ministra Alejandra, Sandra Ferrer.
Thank you,
Voy a dejar con ustedes
Ms. Ferrer.
Ministra Alejandra Lopez
So,
Montoya,
we now have
psicología,
Ms. Alejandra Lopez Montoya, a psychologist and who holds a master's in addiction psychology from the National Autonomous University in Mexico, who has worked as a behavioral therapist for children in the early detection and brief intervention of addictions. She has also been assistant director of the Addictions Center, and also as head of the project of prevention of tuberculosis and respiratory conditions in the strengthening of policies for nicotine control. Ms. Alejandra Lopez, the floor is yours. Thank you. So, to build on what my colleagues have already shared, I am now going to present the development of remote tools for the supervision of students regarding addictions and mental health, as well as for healthcare professionals. The pandemic brought about an increased risk, especially when it comes to a virus infection, but it also brought along activities and tools that allow us to assess mental health and addictions in a way that healthcare professionals must consider, which were already considered before the pandemic, but with the pandemic, it became even more important to consider these, as well as to develop the remote tools that allow us to keep an eye on these circumstances. So the risk of addiction is present, and these tools help us in our preventive efforts and have a better management of those who require a special emphasis in their mental health as well as addiction status, all the while developing tools that allow us to not only assess the risks, but also supervise the students and healthcare professionals who are remotely developing or providing the assistance to those who may have already been undergoing these processes prior to the pandemic, but since the pandemic, the need for better tools was emphasized, not just for the supervision and monitoring of patients, but also the way that healthcare professionals are delivering services. And so first, I would like to share the survey for mental health risk detection related to COVID-19, which was developed on top of a technology platform which contains a survey to detect the risks. And there's a link on the screen, misalud.unam.mx. This tool allows the user to assess mental health risks as well as physical risks. As previously mentioned by my colleagues, the ability to identify a comprehensive health status, which requires monitoring, but also management when it comes to patients. So in this platform, you can access this platform on your mobiles, on mobile devices, and it is possible to complete the survey on your phone or any other devices such as a computer. When logging into the platform, the user can select the type of profile. The pandemic has also caused us to need to identify the needs for mental health support in the community, in the working community of the healthcare professionals. We also work alongside migrants and Mexican immigrants into other countries who can receive the assistance remotely as well. As Dr. Violeta mentioned before, there is a need for written consent and a non-disclosure agreement that informs the users regarding where the information they provide will be stored and how their information will be used. Through this platform, anyone requiring remote assistance and providing personal information such as a cell phone number and email address can also know where their data will be stored, so that before entering into each one of the sections of the survey, the individual may provide or not their consent through the informed consent form, but also through the NDA and the privacy notice. And once agreeing to offer the personal information, the platform shows different screens containing the information where a set of different mental health conditions are assessed. You can see one of the sections of the survey on the screen right now that uses different criteria. The same is applicable to substance use, where the platform, using algorithms, depending on the answer of the platform, can redirect the user through the different pathways of responses. And once the survey is complete, I will now show you what users obtain following the completion of the survey. Again, this is an effort that emerged due to the COVID-19. It considers socioeconomic data as well as mental health conditions through 32 questions, use of alcoholic beverages, and certain behaviors such as violent behaviors, both or as a victim of violence. And I'm now going to share with you information from 8,348 users who have an average of 25 years of age, 50% of whom are single, and something that requires to be identified is the ratio of women to men. Most of the users who have so far answered the survey are women. Following the completion of the survey, this service has also been validated in such a way that, as you can see on the screen now, we have the cause relationship of variables, the way the different bullets are related to one another based on the assessment of the user. And at the start of the pandemic, there were certain categories such as acute stress, and somatization, anxiety based on health, generalized anxiety, and sadness. And even though these would seem to be independent or a large number of questions, the platform also makes smart decisions based on the previous answers and may decide to skip certain conditions on what the user shares with us. This instrument has 0.96 alpha Cronbach with commonalities larger than 0.30 for all of the questions, and an explained variability of 64%. The reason we thought to share this with you is because as healthcare professionals, following this first assessment, we need to use validated, reliable instruments that will allow for the following phases, which I will now share with you. So once the survey has been completed, the platform allows for the user to obtain personalized feedback. And this feedback has been drafted based on not only the assessment, but also certain recommendations through videos, infographics, and also remote learning, e-learning platforms. And towards the end of the feedback, the tool allows for the user to provide their details if they wish to be contacted later, such as an email address or a phone number where they can receive assistance from the School of Psychology staff. A follow-up is very important for the purposes of information traceability, something that I will discuss later on. And as mentioned before, besides becoming this first point of assistance, it also allows for the assessment of risks in mental health, in the mental health field. Here I wanted to share with you a graph, and as you can see, based on the number of people who have already answered the survey, most of these display risk based on healthcare history, both physical and emotional, as well as a generalized health-related anxiety caused by the current conditions imposed on the population by the pandemic. This assessment also allows to guide the way that healthcare professionals are supervised, including supplies that they need. And as you can see, for this graph over here, for the risk assessment and addictions, as you can see, most users are undergoing mild or intensive interventions. They require an intervention which is a little deeper, more guided, and more specialized for their particular circumstances. Another tool, one that overlaps with what we already have, is the IVR, virtual IVR, one that has 30 different phone lines, allowing for remote assistance using phone lines, but also the supervision of the students. Professionals can log into this site using a passcode, and through different situations, a person can listen to the subject of the assessment, provide counseling together, or just provide feedback on the interaction just by dialing the numbers, or download the summary to later provide feedback on it. So this supervision tool is one that simultaneously when used together with the survey, allows for traceability of the whole care process and supervision, which includes the supervision of an electronic record where all the general information is entered, allowing for the supervisors to constantly monitor the care provided to the users. An important consideration is that remote tools allow for a reliable assessment of mental health risks, but at the same time, it allows for remote supervision of healthcare professionals and students to further improve their skills. And we also need to consider the time during which these considerations are taken, as well as variable reactions and social circumstances. Due to the COVID-19 pandemic, some additions have been made to this tool since these changed based on the context and also the time elapsed and new healthcare conditions such as post-traumatic stress and grief. And these are all needed to guide the supervision efforts. Thank you for listening.
Muchísimas gracias, ministra Alejandra López, por esta
Thank you,
tan interesante, sobre todo
Ms. Alejandra Lopez, for this very relevant presentation regarding the impacts that the pandemic has had on mental health. Next, we have Sylvia Morales, she's a professor of psychology with specializes in the psychology of addictions as well as experimental behavioral psychology. She has also been a member of the Committee of Investigators since 2010. She is also a full-time professor of the UNAM School of Psychology and is the academic chief for the master's degree in addiction psychology between 2006 and 2020. She is also the collaborator of the Psychological Services Center since 2006. Dr. Sylvia Morales, the floor is yours. Thank you very much. Thank you for joining us, everyone. I am going to be sharing a conclusion of the work that my colleagues have already been discussing so far during their presentation. And the aim here is to further describe how during these difficult times of the pandemic, the School of Psychology of the National University in Mexico was able to move forward through remote interventions in such a fast way, as we have heard from previous presenters. Before the pandemic, our working group in the School of Psychology were already concerned regarding the gap in the care, in the mental care, and as well as the addiction care realm. And as mentioned, and as we can see on the screen, we had already identified that we only had around 4 healthcare professionals for every 100,000 inhabitants of the country. And in some of the regions, we did not have 1 out of 100,000. That's the case of the state of Tlaxcala and Chiapas. Some of the states had a few healthcare professionals or an important number of healthcare professionals who had the necessary training to provide addiction counseling for anyone requiring these counseling due to healthcare risks or addictions. In the School of Psychology, in some preliminary meetings, we shared how we have been resorting to intensive training as well as supervision and monitoring of all the skills needed for the management, follow-up of risks due to use of psychoactive substances. However, and although we have trained a large number of people in the country, more than 4,000 professionals have been trained, this only represents 1 healthcare professional more per 100,000 inhabitants compared to what was identified before. So it is important to have these professionals providing services at the levels they are. However, this is not enough to cover all the gaps, to bridge the gaps found. So when the pandemic hit, we had already done some intensive work in remote care as described by my colleagues. However, the skills, skill building required during the pandemic was even greater, and this allowed us to reach in a more expedited way communities that most needed it in the country, and as mentioned also even beyond our borders into different countries in Latin America, for instance. But what are the skills and competencies that have already been mentioned, described, and I would only like to summarize concerning the work we have done together with PAHO. This second version of this work with the pandemic, through the training of healthcare professionals, we were able to further promote it. We have a sample of 251 professionals that in the first 6 months of the pandemic were trained with the strategies that have been shared by the previous presenters. Dr. Felix has already explained the value in supervising professional skills during remote care. But how to do this based on the real execution when we are assessing, managing, and providing follow-up to our communities of patients. On the screen, we have some core principles, some essential elements, some assessment principle for the follow-up and of the risk conditions for mental health risks, and as described already by a PAHO, which we were able to directly monitor through remote observation methods that have been described. But what are these core principles we have managed to observe and the level of implementation that has been conducted throughout the first 6 months of the pandemic, or the sample that we see on the screen? And that based on prior evidence, we knew that if the implementation level was around 50 and 70% of evidence-based procedures, this would mean an important impact in those users requiring the service, requesting the assistance. So the core principles of the guide, you may remember we saw this before, this has been implemented for the first 6 months. This goes from the most simple methods, which such as greeting, using simple language, providing the necessary information to the users on how their data will be used, the confidentiality of their information, the use of strategies that respect their risk condition, but also provides the necessary recommendations. These core principles in the guidelines are, as you see on the screen right now, based on the implementation level that trained healthcare professionals through the strategy were able to implement throughout the first 6 months of the pandemic. Please note that some of these skills are easy to implement. As we see here, 99% of all the real-time skills, such as greeting, using clear, easy to understand language, but there are several others that have a lower implementation level that are nonetheless within the same range specified before, known as sufficient, or the minimum dose of the active ingredient of care, which reflects in the successful psychological intervention initiatives. As you can see, summarizing or repeating the key points reaches a 74% of implementation, and this is within the ranges identified previously as being sufficient to achieve adequate impact. So the average core principles recommended by the guidelines, the compliance was around 89%. Essential elements in the guideline relate to inquiring the reason, the consultation, the presence of other common manifestations of disorders, as well as those related to physical health, use of medicine or family history relating to these conditions, as well as psychosocial history, factors that need to be addressed during the management phase. As you can see, the average of essential elements that were successfully implemented during the remote care sessions in the first 6 months was of 56%. This provided us with the elements that allow us to understand what the best way would be to provide feedback to healthcare professionals in order to strengthen their skills when working remotely to guarantee an efficient impact in their psychological interventions. And this relates mainly to the inquiry skills, which is you could see were low at the time of the assessment when it comes to both mental health risks and physical health, which were pretty low, around 45% at the time. These two examples are below the minimum implementation levels that guarantee successful remote psychological intervention. And just by using this direct observation tool to assess skills using Zoom and using the virtual IVR and remote interventions, which were implemented starting in March of 2020, provide a very good idea of where strengthening is required. PAHO recommends promoting and increasing the level of use. And the average essential elements is around the same rank, in the same range as we see here on the screen. But this does not necessarily mean that no further strengthening is required. Now, when it comes to management, during remote assistance, and once we receive approval, the authorization of the users, we have been following the recommendations of the five fingers that we promote, which are planning of the treatment, psychoeducation, daily activity, functioning, psychological counseling, and pharmacological treatment. Channeling to the necessary specialist or third level hospital needs to be one of our strategies once we determine that the risk is high when it comes to emotional health and mental health. So the assessment of the level of implementation of our healthcare professionals in these skills have been assessed. These skills are basic. When it comes to treatment planning, we find that 61% of the implementation was achieved for the adequate referral, for target compliance, and for development of service plans which are necessary for the patients, for their strategy, and for the planning of the duration of the strategy. Now, regarding psychoeducation, the implementation level achieved was 64%. This means the need to explain to the person the symptoms, the treatments available for them, the way that the caregivers can become involved in the care, and the best way to explain to them what is happening with the patient. And regarding stress management, we achieved the 70% of this compliance of this goal. As healthcare professionals, then we need to be able to identify psychosocial factors, teach stress management using relaxation strategies and problem-solving strategies, but always based on what evidence has already shown to be effective, modeling the practice of health practices and the feedback of healthcare professionals, which the healthcare professionals provide during the management. So for this, we had an average 70%, a good number too. Regarding daily activities, this is one of the areas that requires much closer attention from HCPs. Although we know that promoting mental health and preventing psychoactive substance use requires healthy sleep, healthy diet, and setting routines, we need to find ways to promote these healthy activities. And here, the implementation level was quite low at the beginning of our implementation. And this has been one of the areas we have promoted more. Community activity to the third level of care. Activities such as promoting physical activity and adequate nutrition, as well as having a healthy and repairing sleep patterns. This through positive feedback that the HCPs need to provide patients when having an intervention like this. Referral to psychological counseling is essential. 76% of remote activities have resulted in such a referral. Pharmacological therapy is another option, even though following the guideline recommendations, not every patient is medicated. Pharmacological interventions are only required in certain very specific cases. However, compliance strategies are needed when pharmacological therapy is required. Also, a better explanation of the best pharmacological treatments for the patient and the mechanisms of action for the patients to be able to complement their psychosocial interventions with pharmacological therapy. And finally, a referral when a third level service is required to expedite this referral when needed. So through focusing in the assessment, management, and follow-up, as we see on the screen right now, we have promoted this reinforcement of treatment compliance, promoting the adherence to both the pharmacological and psychosocial therapies and assessing the treatment response, as well as an assessment of the compliance of the different methodologies explained. So here we have a compliance of 91% for treatment adherence. And based on evidence collected in in-person care, where the effectiveness range is between 50 and 70% of intervention, evidence-based intervention, the ranks here were a little broader, a little higher compared to the guideline recommendations. We also found where we needed to strengthen our interaction with the users of the service to guarantee a better and more effective intervention. And within the satisfaction levels and assessments of all care professionals that were reviewed, we find some very good reviews with several users reporting to feel happy and comfortable with the intervention. We are reaching this goal that is recommended by the guideline, which is more empathetic treatment, evidence-based, yes, but also with a certain quality of warmth, which will further foster the compliance of the therapy or the strategy. Users report to feel like they're listened to, they feel like they're paid attention to, that the intervention has helped them recover their sense of control, feeling like they are leading happier lives following remote interventions via Zoom, IVR, or local phone systems. And based on these strategies shared by my colleagues, and in this conclusion, I can share with you that from March 2020 to date, we have had more than 173,000 sessions at the national level. This includes training, remote training to HCPs, around 4,000 of them, community care and informal care, which relate to the automatic delivery of infographics, videos, higher education, and this has also had a high number of users. Primary health, self-care, also cases around 10,500 cases. The second level of care through the virtual IVR, more than 18,000 users of post-traumatic stress disorder and substance use, among others, and more than 7,000 for other more specialized services related to violence, depression, self-injury risks, three of the most relevant risk causes during the pandemic. So through this strategy, both informal services, self-care services have been planned, These go from the highest possible need, where there is a great prevalence of or number of people requiring the service, all the way to those that would seem smaller in terms of numbers, but require a much more specialized and higher cost, but also higher level intervention, meaning that it goes from low to high cost strategy, but the methodology allows us to bridge the gap across the different levels of service that our community needs. And next, I would like to thank those who have made this strategy possible. The numbers sound good, but as you have heard today, every person, the actions of every supervisor and HCP that has participated has been a true achievement, a great effort, something that could not be a reality without their constant communicating, their constant collaborating. Before the pandemic, which allowed us during the pandemic to use the technology strategies in a way that they promote and improve and expedite the care, always based on evidence and based on the monitoring of healthcare professionals that have been collaborating with us and continue to collaborate with us. Thank you so much. And this is the end of my presentation. Thank you. Thank you, Dr. Sylvia, for such a great presentation and conclusion to the presentation of the work of the National University in Mexico, UNAM. And thank you to the four panelists, Sylvia Morales, Sandra Ferrer Reyes, Alejandra Lopez Montoya, and Dr. Felix Romero, for your participation in the remote tools panel and supervision in the field of addictions and mental health. And I would also like to thank everyone else who have participated in the chat. And please stay with us, continue to participate in the activities of this meeting. Thank you, and have a great rest of the day. From Washington, and have a good day. Thank you.